Hi there, Corazon volunteer. This is Katherine Eichman, the co-chair of Corazon Clinic, and in this video I'll be walking you through an example chart. This example will be quite simplistic, but it will help you understand the basics of charting and what we're looking for at the clinic. Again, here's the exact SOAP note that we use at the clinic. We'll be filling out this chart together in its entirety, but before we get started with an example, let's review the note again together so that you can become familiar with what you need to fill out and what goes where. Starting at the top left, we have the clinic's information, followed underneath with the patient's demographics. Then we have the chief complaint or the reason for the visit. Underneath the chief complaint, we have the start of the subjective section, which is a space for the HPI or the history of present illness to be documented. If we jump to the top right box, we have some more subjective information such as insurance status and allergies, and there's also a box that pertains to the problem list or the medical history. Again, please note that the medical history is documented on a separate sheet in the chart, so be sure to review that before seeing the patient. In the middle box, we have the objective section, which includes the physical exam. And then if we jump down to the box and on the left-hand side, we have the vitals. Again, these are part of the objective data, not the subjective data, even though they are positioned right underneath the subjective section. The picture at the top right can also be used to objectively document what area of the body the patient's complaint pertains to. Again, this is normally used to document an injury or a location of a skin issue. Going down to the bottom right, we have the assessment or the diagnosis section, and then also the plan section. And then going back up, we have the notes section, which is a great place to jot down your thoughts, your impression, make a differential list, or put in a future plan. Lastly, if we look at the very bottom, we have the provider name, volunteer name, room number, and follow-up time listed. It's imperative that these sections are filled out, so please make sure that you do so. Without volunteer names, we have no clue who it belongs to or which team saw which patient. This becomes a problem when there's a question for the team or if there's a mistake that needs to be corrected. The provider name is equally as important, not only for legal reasons, but also for the pharmacy, who will sometimes need to ask the provider some clarifying questions. Lastly, follow-up time is also important because it tells the pharmacy staff how much medication to dispense. If you don't put a follow-up time there, the pharmacy has to stop what they're doing, go and find you, ask you how many weeks you want to dispense. So it will just save you a lot of time if you can please put the follow-up information. So now that you're aware of the chart format, let's go ahead and start with an example. First, in the top left of the chart, we have the patient demographics. This portion is normally filled out by the admin staff and is usually not your responsibility. However, with that being said, please make sure that it's filled out correctly with the correct patient name, the date of service, the date of birth, and the medical record number. So here's an example, and we're going to fill this out together. So after pulling the chart, you'll find the medical record number on the outside of the chart written on the folder and also on the medical history sheet. So you'll just go ahead and make sure that the medical record number is there and that it's correct. Then next, you'll have the patient's name that is also stated there. And then we also have the date or the date of service, the date that they're being seen. Next, we have the patient's date of birth, making sure that this is correct. Once you gather a patient and call their name, ask them their date of birth to confirm their identity. And then we have their gender, male or female. Next, we have the reason for visit or the chief complaint. And again, this is also normally filled out by the admin staff. However, just a tip for those who are working in the admin or the front desk, just don't state refills. If you know what they're coming in for, if you know what the condition is, if they know what the condition they're presenting with, please state it here. Also remember that if it's something odd or unconfirmed, you can put it in quotation marks, especially if it's something that's kind of out of the ordinary. So here is the top right part of the chart. Again, this section is kind of a mix of different things with objective information, subjective information, and also some notes. But this needs to be filled out at every visit, specifically the subjective information. So please make sure that you ask them these 2 questions at every visit, and also ask them or look at their problem list. So first we have insurance status. You'll circle 1 if they have insurance. right yes, or if they don't, no. So if they don't have insurance, circle no. If they do have insurance, circle yes, and then please write what kind of insurance. Normally it's Medicare, sometimes Medicaid. Next, we have the problem list. So again, this is the medical history. Oftentimes, people just check this box without looking at the medical history. So please make sure that you look at the medical history and then check the box. Again, it's asking you if you check the problem list. If you didn't check it, don't put a check mark here. But let's just say you're being a good student and a good volunteer, and you went and looked at the medical history, and so now you can go ahead and put a check mark there. This needs to be asked at every single visit. That's going to be their allergies. So we have penicillin, aspirin, latex, sulfa drugs, and then no allergies. Some people have other allergies, and you would write them in here. So let's just say, for example, this patient has a sulfa allergy. Next, we have this person here. Again, we document the location of different findings here, or if they have a complaint. So let's just say the patient had a complaint of his right foot, so we would circle the right foot. But if they had something on their left hand, we would then circle the left hand. If they had something on the right eye, we would circle the right eye. I think you get the picture. And then for the note section, again, I like to document any changes to the medication, a differential list, any other thoughts, any other instructions that I want the next team to do or them to look at. So for an example here, I have the patient was started on metformin 500 milligrams daily. Please check blood glucose at the next visit. So when you're reviewing the chart and you look at the notes, you'll see the thoughts from the previous team. So for our example chart, we'll fill out this top portion together. First off, we're going to ask them if they have insurance. Sir, do you have any kind of medical insurance? No. Okay, then we'll circle no. You don't need to write anything if they don't have insurance. Next, we are going to make sure that we check the problem list. You should do this before you see the patient so you can be familiar with their medical history. So again, you are a good volunteer. You looked at their problem list or their medical history, so you can check that box. And then we're going to ask the patient if they have any allergies to any medications, food, or substances. And this patient says, yes, I have an allergy to sulfa, so you will circle sulfa. If they say, oh, I have an allergy to bee stings, you would write, bee venom here, etc. So now that we have our demographics filled out, we asked the patient about their insurance and their allergies, and we also looked at their medical history. We can start with the subjective interview. So that again is the history of present illness. So again, we can use old carts, and this is not always necessary for everyone. Old carts always doesn't fit in, and we'll see that with our example today. But let's just say our patient is coming in for high blood pressure. So that's the chief complaint, is high blood pressure. When you interview the patient, you can ask them the onset, when did this start? And they said it started about 10 years ago. For location, not applicable. We don't put heart or arteries or veins for high blood pressure. For duration, also not applicable. Character, not applicable. We have aggravating and ameliorating factors, which we can write, and also associated symptoms. So these are just some review of systems or ROS questions that I will typically always ask for someone who's coming in with high blood pressure. So I put, or I will always ask, do you have any chest pain, headaches, blurry vision, shortness of breath, heart palpitations, or dizziness? If they say no to all of that, then we would write denies in front of that. If they do have chest pain, we would say reports chest pain and give a little bit more information about that. For aggravating and ameliorating factors, don't really have much aggravating factors here, but for ameliorating, medication is one of those. So you can put takes lisinopril 20 milligrams a day, and their last dose was taken yesterday. This is really important in our population. When was their last dose taken? Some patients are very compliant, and some will have their bag stolen or just be really incompliant. And you'll see some people take their medications weeks ago, months ago, and it could be a couple days ago. Just depends. Next, we have radiation, not applicable here. Timing, not applicable, and severity, not applicable. So you can see how old carts really doesn't fit high blood pressure too well. But let's move on to the history of a present illness in a narrative form. So let's just say we got all of that history, and I will just show you a typical narrative of someone who presents with multiple conditions such as hypertension or diabetes and some joint pain. This is a typical case. I'm making this very easy for you guys right now, but I just want to show you what a narrative looks like. So we have a patient is a 59-year-old male who presents to follow up on diabetes type 2 and hypertension. His current medication regimen includes metformin 500 milligrams once a day for diabetes and lisinopril 20 milligrams for hypertension. Last dose was taken last night. He also takes Tylenol 500 milligrams PRN or as needed for bilateral knee pain. He denies polyuria, polydipsia, polyphagia, those are the 3 P's for diabetes, numbness and tingling for diabetes, chest pain, dizziness, blurry vision, shortness of breath, heart palpitations, headaches, and nausea and vomiting. Those are more relatable to the hypertension. He does not self-monitor his blood glucose or blood pressure. Last meal was around 8 p.m. Patient is fasting this morning. Knee pain is chronic, onset about 5 years ago without trauma. Patient states he was diagnosed with arthritis. Pain is exacerbated by prolonged standing and with walking. Pain is better with rest and Tylenol, and he requests a cane for walking assistance. So you can see I threw in some old cards there and I put it in a narrative form. But this is just a general narrative summary of why a patient or of an HPI. So it's a pretty classic example, and there are some really simple cases and some not so simple cases, but this is just an example to show you. Now, moving on to the objective section, we'll go to the physical exam. Typically, I will do vitals first before moving on to the physical exam, but I will show you guys the exam portion first. So we have general appearance. Again, you are assessing if the patient is in distress or not. In this case, my patient is not in distress. He is perfectly happy and well content. So we're going to put no apparent distress or NAD. Next is our neuro section. Since he's not complaining of any numbness or tingling, I'm not going to do a neurological exam, but of course if he was, as a sequela of his diabetes, we would do a neuro exam here. And again, at Corazon, we chart the psych section in neuro. So here we have learn oriented or A&O times 4. Next we have the GI exam. I don't really think it's pertinent to do a GI exam with this case, so we will put detailed exam omitted and in parentheses DEO. Now the next time we need to omit an exam, we can just put DEO. Next for musculoskeletal, since he is complaining of knee pain, go ahead and just assess the knees. Go ahead and look at them, feel them. So here we have the medial joint line of the right knee is tender to palpation, and the lateral joint line of the left knee is tender to palpation. You can do some other orthopedic exams as well. Also look for swelling, effusion, any kind of bruising, especially if there's any trauma you'd want to document. But for just a simple example, this is pretty straightforward. Next is the gait posture transfer. Again, you can just observe this by watching the patient walk, by looking at them while they're sitting there. In this case, you called the patient back to the exam room and you walked behind them as you and told them which room that you'll be in. So you say, "Sir, we're going to be in room 4 today. It's up ahead on the right-hand side," and then they would go ahead and walk, find room 4, and you would be observing them as they walk. So let's just say you do that and you notice that they are limping, and that is classified as an antalgic gait. So you would document antalgic gait. If it was normal, they were ambulating normally, you would just put gait and station intact. Next for HEENT exam, don't feel like that's pertinent to today's case, so we're going to put DEO. Respiratory exam, again, you can always do this, really easy exam to do. So let's just say that you auscultated both sides of their lungs. So you would, and it sounds clear, you didn't hear any kind of abnormal sounds, you would put CTA of posterior and anterior lung fields bilaterally. And just a reminder again, CTA means clear to auscultation. Next for cardiovascular exam, this is going to be a must for anyone with hypertension or diabetes, is the auscultation of the heart. So let's just say that you listen to their heart It was not tachycardic or bradycardic. You didn't hear any kind of abnormal heart sounds or murmurs, so you would document that as RRR, which is regular rate and rhythm. No murmurs, clicks, or gallops. And again, if their heart rate was 100 or above or 60 and below, you would put bradycardic or tachycardic. And then for skin, for a general skin exam, you can just look at them and just take a quick peek at their skin. Warm and dry is the typical classical answer. And so that's really all you need to put unless they have a skin complaint or they have something noticeable that you need to document. And now for the vitals section, we have BG for blood glucose. Let's say you measured his blood glucose and remember that he ate at 8 p.m. the evening prior, so he is fasting. You would put what number that you got from the glucometer, let's say in his case 180, and since he was fasting, this is also known as preprandial, so you can put preprandial or fasting. Next, for blood pressure, you took his blood pressure and you got 128/80. Next is heart rate. You can do this manually or with the pulse ox machine, and you got 84, and this is a regular rate. Next is the respiratory rate. You went ahead and observed that and got 12, and upon coming in we took their temperature, and so we have that documented, and you can write it again here, 98.6. And then for pulse ox, which you used with the pulse oximeter, you got 98%. So that is just a classic example of a typical easy physical exam to chart, nothing too difficult, just very simplistic and simplistic vitals. So after you've gathered the HPI, physical exam, and vitals, you'll present your case to the provider. The provider will then provide a diagnosis and a plan, and this is where you document that information. The assessment section is where the diagnosis is documented. We start with number 1 and then work our way down numerically. This patient has a few chronic conditions, so we can already assume what the diagnosis is. We have hypertension and diabetes. For hypertension and diabetes, we want to specify if their condition is controlled or uncontrolled. This is very important to specify. Again, we know this from the different standard of care guidelines specific to each disease. For hypertension, a patient is controlled when their blood pressure is under 130/80. Our patient's blood pressure was 120/80, so technically they're in goal. Therefore, the hypertension is considered controlled. If their blood pressure was 154/82, then we would state uncontrolled. Our next diagnosis is diabetes type 2. Again, state if their diabetes is under control, meaning that the blood glucose is in acceptable range. According to the ADA, the fasting glucose of a patient who has diabetes should be under 130. Our patient's blood glucose is 180 fasting, so they're not within their goal. Therefore, their diabetes is uncontrolled. Our third diagnosis is bilateral primary osteoarthritis. This is their diagnosis because the patient already had a history of osteoarthritis or just normal wear and tear arthritis. If they presented with knee pain that was new or no prior diagnosis, we would just state bilateral knee pain. We wouldn't assume that it was arthritis or anything like that. And that's because we don't have any kind of diagnostic imaging like an x-ray to be able to use to diagnose or rule out arthritis. So now that we have the diagnosis, the provider can then make the plan. And before we get to that, this is just a reminder that my biggest pet peeve are those who copy word for word the past plan section. And this is how mistakes are carried on from one chart to the next and kind of spiral out of control from there. Just remember to confirm your doses with the provider and make sure you're writing the correct dose and instructions. Oftentimes what happens is that the doses are copied from the last chart, but sometimes these doses are incorrect. So of course it's fine to look at the past chart to see what they were taking. That is necessary, but just make sure that the correct doses are being copied over. If you have questions, go ahead and please ask your provider. Okay, so I'm off my soapbox, back to the plan. So the plan is what we are going to do about the diagnosis. Well, in this case, we're most likely going to be refilling medications and then probably changing the dose of one since the diabetes is uncontrolled. So for the plan here, we put the correlating numbers 1 and 1. This is a refill, so we're going to state refill lisinopril 20 milligrams, and then we're going to write out the full SIG and specify for how many days they'll be taking this. So take 1 tablet by mouth once a day for high blood pressure for 7 days. That is for hypertension. For number 2, diabetes, we are going to start metformin 500 milligrams. We're putting start because we're increasing the dose. If we were just keeping it at the same dose, we would put refill. And if we weren't refilling it, we would just put continue. But for this case, we're increasing the dose, so we're going to put start metformin 500 milligrams. Take 1 tablet by mouth twice a day for diabetes for 7 days. Next is 3 for the arthritis. We are going to refill their Tylenol 500 milligrams. Take 1 to 2 tablets by mouth every 4 to 6 hours as needed for knee pain. And I just put dispense 21. That should last them about a week or 2. Hopefully a little bit longer than that. For the NSAIDs or the other pain medications, please make sure that you write out the full SIG. Oftentimes people just put Tylenol. Again, we need instructions on how to take this. Just putting Tylenol is not acceptable. And then also for number 3, since it's the same plan for the same diagnoses, or the plan for the same diagnoses, we'll put 3. And in this case, we are giving this patient a walking cane for assistance, so we will document that in the chart. So next we're going to go right back up to the top right section, and we're going to write in the notes section since we changed the medication dose. So I just want to document here that the dose of metformin was increased from 500 milligrams once a day to 500 milligrams twice a day. So please check blood glucose at next visit. This will let the next team who sees the patient next week to go ahead and perform blood glucose to assess how the medication was working for them. So moving on, we have the last part, which is making sure that you document the provider name, volunteer name, room number, and follow-up. So we'll document that here. The provider that you consulted with was Dr. Sarah. We have our volunteer name, so we'll say Kat and John, and then our room number was number 4, and we're going to follow up with this patient in 1 week because we changed one of their medications, and we want to evaluate how they're doing next week and how that medication worked for them. So here we have the chart in its entirety. We'll go ahead and make sure that we see all of this here, but we had the patient's demographics, we had the chief complaint, we asked them about their insurance status, we checked their problem list, we asked them about allergies, and then we gathered the HPI. Next we took our vitals, and then we started performing some physical exam. Write down our physical exam here, and then after that we consulted with our provider and we wrote down our diagnoses: hypertension, diabetes, and osteoarthritis. And again, we labeled if the diabetes and hypertension were controlled or uncontrolled. And then we went ahead and wrote out the plan, what we're going to do about the diagnosis. We are going to refill lisinopril, start metformin because we're increasing the dose, and then we're also going to refill Tylenol as well. And we're also going to give him a walking cane for assistance. We're going to make sure that we have our provider name, our volunteer name, our room number, and our follow-up time. And then also, just because we did increase one of his doses of his medication, we have the note section that the dose of metformin was increased from 500 milligrams daily to 500 milligrams twice daily. So please check blood glucose at next visit. And so when the next team sees that the following week, they'll be able to know what they need to do and assess how that medication worked for them. So that is the example of a chart for you guys. Again, this is pretty simplistic. I'll have a couple more examples that may be a little bit more complicated.